Today we'll talk about the celiac disease. Celiac disease is a chronic immune-mediated disorder of the small intestine that occurs after exposure to the gluten in genetically susceptible individuals. This disease is an important cause of the malabsorption and is frequently underdiagnosed in the clinical practice. Celiac disease is an autoimmune condition. It is not actually a food allergy, and it is not the same as the simple gluten intolerance. Gluten is a protein found in the wheat, barley, rye, and oats. In affected individuals, ingestion of the gluten leads to immune-mediated damage of the intestinal mucosa, particularly the villi, resulting in the impaired absorption of the nutrients. The worldwide prevalence of the celiac disease is approximately 1%. It can present in any age and is more common in females. It is also strongly associated with other autoimmune disorders such as the type 1 diabetes mellitus, the autoimmune thyroid disease, and with the genetic conditions such as the Down syndrome. First degree relatives of the affected person also have an increased risk. Almost all patients with the celiac disease carry either the HLA-DQ2 or the HLA-DQ8 genotype. However, genetic predisposition alone is not sufficient. Exposure to the gluten is required to trigger the disease. After gluten ingestion, it's broken down into the gliadin peptides. These peptides cross the intestinal epithelium and are deaminated by the enzyme tissue transglutaminase. The modified gliadin is then presented to the CD4 positive T lymphocytes, leading to the activation of both cellular and the humoral immune responses. Autoantibodies are produced, including the anti-tissue transglutaminase antibodies and the anti-indomycin antibodies. These immune responses causes the characteristic histological changes in the small intestine, including the subvillous atrophy, crypt aplasia, and the increased intraepithelial lymphocytes. As a result, the absorptive surface area of the intestine is markedly reduced, leading to the malabsorption of fats, iron, calcium, folate, and fat-soluble vitamins. Now we will talk about the clinical features, including gastrointestinal feature is the chronic diarrhea, steatorrhea, fatty stool, abdominal bloating and flatulence, weight loss, failure to thrive, and growth retardation in the children. Extraintestinal features including iron deficiency anemia, which is resistant to the treatment, chronic fatigue and weakness, osteoporosis or the osteomalacia, delayed puberty, infertility, and the recurrent miscarriages in females. Peripheral neuropathy, recurrent optic mouth ulcers, depression, and irritability, including skin manifestation, is the dermatitis herpetiformis. Dermatitis herpetiformis is actually because of the IgA deposition on the dermo-epidermal junction. Intensely itchy, vascular rash on the extensive surfaces such as the elbows, the knees, and the buttocks. So now we'll talk about the important investigation in case of the celiac disease. The first one is the anti-tissue transglutaminase Ig antibody, which is the first line screening test in the serology. The second one is the anti-indomycin antibody, which is highly specific in this case. Total serum IgA level to rule out IgA deficiency. Duodenal biopsy is the gold standard in this case. Duodenal biopsy which shows the villus atrophy, the crypt hyperplasia, the increased intraepithelial lymphocyte can also be detected in this case. HLA-DQ2 and HLA-DQ8 genetic test is also important in this case to exclude disease if negative. This disease can cause severe complications of specifically the severe malnutrition, including iron, folate, calcium, and vitamin deficiencies, osteoporosis and the pathological fractures, infertility and the recurrent pregnancy loss, growth retardation in the children, enteropathy associated T-cell lymphoma, and the small bowel adenocarcinoma. The treatment options including dietary management, lifelong strict gluten-free diet, avoid wheat, barley, rye. Allowed rice, maize, potatoes, millet, quinoa, buckwheat, gluten-free oats. And then go for the correction of the deficiencies, including iron, folic acid, vitamin B12, calcium, vitamin D, and monitoring is also important in this case. Clinical improvement of the anti-TTG antibody levels, bone mineral densities in adults, refractory celiac disease, suspecting if no response after 12 months. And management include corticosteroids, immunosuppressive therapy, specialist referral, dermatitis herpetiformis, gluten-free diet, and the depsone for the rapid symptoms control. So this was all about the celiac disease.